Good morning. Today we will talk about second part of childhood anemia. The objectives of this lecture: first, to define hemolytic anemia and list the sites of hemolysis. Then we'll describe the presentation and management of G6PD, autoimmune hemolytic anemia, thalassemia major, and sickle cell disease. Hemolytic anemia describes a group of anemia that are characterized by abnormal destruction of red cell, leading to anemia, reticulocytosis, and indirect hyperbilirubinemia. The hallmark of these disorders is reduced lifespan of RBC rather than underproduction by the bone marrow. Normally, the RBC survives in circulation for about 120 days, but in hemolysis, the cell survival times is considerably shortened and may be as short as 90 days. This is a picture for child with pallor and jaundice, characteristic of any hemolysis. What are the sites of hemolysis? First, intravascular hemolysis, when the RBC are rapidly destroyed within the circulation with liberation of hemoglobin, like glucose 6-phosphate dehydrogenase deficiency, hemolytic uremic syndrome, disseminated intravascular coagulation following a transfusion of ABO incompatible blood, hemolytic anemia due to prosthetic cardiac valves, and paroxysmal nocturnal hemoglobinuria. Second, extravascular hemolysis. The RBC here are removed from circulation by macrophage to the reticuloendothelial system, mainly liver and spleen, where they are destroyed there. For example, autoimmune hemolytic anemia and hereditary spherocytosis. The third site is intramedullary hemolysis, and it occurs in the bone marrow when fragile RBC precursors are destroyed prior to release into the circulation because of ineffective erythropoiesis, for example, thalassemia major. The lab findings, which are commonly present in any child with the childhood anemia, are due to an increased RBC breakdown, whether intra or extravascular hemolysis. There will be an increased unconjugated serum bilirubin, increased urine urobilinogen, increased fecal stercobilinogen, and absent serum haptoglobin when it becomes saturated with hemoglobin. Haptoglobin is a protein binding free hemoglobin in circulation, and when it becomes saturated, the excess free hemoglobin will be excreted by the kidney, causing hemoglobinuria. As a result of increased RBC production, there will be reticulocytosis and bone marrow erythroid hyperplasia. Other lab finding: due to damaged RBC morphology, there will be microspherocytes, elliptocytes, and fragmented RBC. Osmotic fragility is decreased in cases of hereditary spherocytosis, as well as shortened RBC survival. Classification of hemolytic anemia. First, we have inherited disorders like RBC membrane defect in hereditary spherocytosis and hereditary elliptocytosis, enzyme defect in G6PD deficiency and pyruvate kinase deficiency, or hemoglobin defect in thalassemia syndrome and sickling disorders. The acquired disorders are either immune-mediated in autoimmune hemolytic anemia, or alloimmune in hemolytic disease of a newborn, or hemolytic transfusion reaction, or maybe non-immune and traumatic, involve prosthesis, microangiopathy in hemolytic uremic syndrome, infection, drugs or chemicals, hypersplenism, or secondary liver and renal diseases. We start with G6PD deficiency. It is the most common RBC enzyme defect. It is inherited as sex-linked recessive disorder, usually affect males while the females are carrier and they show half normal RBC G6PD values. The female can be affected when she is homozygous or when she has one X chromosome in Turner syndrome or random inactivation of normal X chromosome in lionization theory, associated with potentially life-threatening hemolytic disease because of severe deficiency. Usually, the type of G6PD deficiency present in the Middle East is B-, which is associated with severe deficiency of the enzyme and severe hemolysis after exposure to antioxidant drug infection or ingestion of fava beans, while other type, which is A-, is present in a Black population, and it is associated with moderate deficiency of the enzyme and hemolysis during exposure to specific drugs like anti-malarial drugs. As a result of G6PD deficiency, there will be oxidative damage to RBC because they lost the protective effect of the enzyme G6PD. So the cells cannot convert the oxidized substrate to a reduced state, causing their destruction. Clinical presentation in neonatal period, it usually presents as neonatal jaundice, appears by age 1 to 4 days and might require exchange transfusion. Beyond neonatal period, the patient will develop acute hemolytic anemia, and typically most of the patients are asymptomatic unless they are exposed to an exciting agent or antioxidant drug, chemical infection, or ingestion of fava beans. The onset of hemolysis usually starts within 24 to 48 hours of exposure. Other non-specific symptoms is acute abdominal pain, vomiting, or diarrhea. Hemoglobinuria, when after destruction of RBC and liberation of hemoglobin, as we mentioned, it will bind to haptoglobin, and the excessive hemoglobin that is not attached to haptoglobin will be excreted by the kidney and causing cola-colored urine or due to hemoglobinuria. The patient will have jaundice, symptoms of anemia such as lethargy and irritability. Cardiovascular decompensation may occur in severe cases. Most acute hemolytic episodes are mild and self-limiting, even with continuing exposure, because there is an increased level of enzyme in the remaining younger population of RBC. Anemia usually resolves in 3 to 6 weeks. Other possible complication is renal failure due to clogging of renal tubules by free hemoglobin. Also, death might follow a severe hemolytic event. Outside the episode, there is no evidence of a chronic hemolysis. Diagnosis during the attack, we can have the following lab finding. First, anemia, and in a peripheral blood film smear, we will see normocytic normochromic RBC, small cells or poikilocytes. Some of them are spherocytic or fragmented. The characteristic findings include bite cells. Also, there will be reticulocytosis. Hyan's bodies, they are inclusion bodies seen in the RBC composed of denatured hemoglobin with stromal protein. They are detected by using special supravital stents. However, the Hyan's body are present in the circulation only in the first few days following hemolysis. Then they will be removed rapidly by the spleen. As a result of intravascular hemolysis, the serum haptoglobin is reduced. There is increased unconjugated hyperbilirubinemia, in severe cases, hemoglobinemia and hemoglobinuria. This is a blood film for a patient with G6PD showing spherocytes and a fragmented RBC. This is a urine sample from a patient with G6PD deficiency. The left sample showing the urine color during the acute attack which is cola-colored urine, and as hemolysis stops, the color of urine will be clearer until it reaches the normal color in the right sample. This is a picture for Hyan's body in a slide stand by supravital stents. Another picture for Hyan's body in G6PD deficiency. Diagnosis of G6PD can be detected using several screening tests to assess the level of enzyme, quantitative or qualitative, and these tests should be done 6 weeks after the attack to know the real level of G6PD in the cells. The blood count between the attack is normal. Treatment during the attack, we should remove the offending drug and treat underlying infection. We should give the patient excessive fluid for brisk hydration, as we mentioned, to ensure adequate urine output that will prevent clogging of renal tubules. Transfusion may be necessary in severe hemolysis, and before discharge, we should teach the parent to avoid any oxidant drug, chemicals, or ingestion of fava beans in the future. The second type of hemolytic anemia in children is autoimmune hemolytic anemia. It is due to production of antibodies against an individual own RBC membrane antigen causing hemolysis. This is usually occurs secondary to infection or drugs taken by the child. The acquired form of hemolysis with the defect outside the RBC due to presence of autoantibody. It is divided into warm and cold type, depend on the reaction of antibody with RBC required temperature. For example, in warm type, the reaction occurs better at 37 degrees Celsius, while in cold type, the reaction between RBC and antibody occur at 4 degrees Celsius. The peak incidence occurs in a preschool age group. Hemolysis is largely extravascular, involving IgG antibodies, and occurs primarily in the liver and spleen. Clinical features: the child present with pallor, jaundice, non-specific symptoms like lethargy, abdominal pain, or low-grade fever. If hemolysis is severe, the urine may be dark. There is hyperdynamic circulation due to drop in hemoglobin, also a large liver and spleen. This is due to destruction of RBC coated with antibody in the reticuloendothelial system. This enlargement of liver and spleen can differentiate autoimmune hemolytic anemia from G6PD, in which the patient doesn't have any enlarged spleen or liver. The lab finding anemia with low or very low hemoglobin level. The peripheral blood smear similar to G6PD will show prominent spherocytes, polychromasia macrocyte. Autoagglutination can occur if we leave the RBC at 37 degrees Celsius due to reaction of antibody with RBC. Reticulocytosis is common. Evidence of hemolysis will lead to hyperbilirubinemia, decreased haptoglobin level, hemoglobinuria, increased urinary urobilinogen, and in the most important lab finding in this disease is positive direct Coombs test. This is a peripheral blood smear showing red cell agglutination. Treatment of autoimmune hemolytic anemia: most of the patients have mild anemia of limited duration, therefore they do not need therapy. And in compensated hemolysis, we just observe the patient and give him folic acid at an oral dose of 1 milligram per day. But when he has decompensated hemolysis, then definitive therapy is indicated, depend on underlying cause, like steroid therapy, intravenous intravenous immunoglobulin, and in severe chronic long-standing cases, we can do splenectomy. Blood transfusion only given in life-threatening situation as a temporary solution while waiting for other treatment modality to begin working, because it is very difficult to get incompatible blood for this patient due to presence of antibodies. So we should give the patient the least incompatible blood, or the blood which gives the least reaction under cover of steroid. Now we talk about thalassemia syndromes. They are inherited group of disorders of hemoglobin synthesis result from alteration in the rate of globin chain production. The common type of thalassemia syndrome in the Middle East is the Mediterranean Cooley's anemia or beta thalassemia major due to partial or complete reduction in beta globin chain production. The clinical severity widely varies, ranging from asymptomatic form to severe or even fatal disease. Thalassemia minor is due to deficiency of one beta genes. It leads to no significant hemolysis, no unusual signs or symptoms are encountered. In thalassemia major, due to deficiency of both genes, it leads to significant hemolytic anemia. While in thalassemia intermediate, here the degree of hemolysis is milder, even though the patient have deficiency of both beta genes, because the patient need minimal or no need for a transfusion. Clinical features: usually anemia becomes apparent between 3 to 6 months, because at this time the prominent hemoglobin in the baby is hemoglobin F, which contain alpha-2 and gamma-2. But when production of hemoglobin declines, then the symptoms and the clinical manifestation of beta thalassemia will appear, because fetal hemoglobin doesn't contain beta chain. So during the first year of life, the baby will present with a progressive anemia and failure to thrive, hepatosplenomegaly, and jaundice. The severity of this anemia is due to combination of ineffective erythropoiesis as well as short survival of RBC in the circulation. As a result of hemolysis, this will lead to extramedullary hemopoiesis with expansion of the bones, leads to thinning of the bone cortex and tendency to fracture. Also, the patient will have bossing of skull and the specific facies with hair on end appearance seen by X-ray. They are liable to develop gallstones and chronic leg ulcers. Due to repeated transfusion and increased absorption of iron from the bowel due to ineffective erythropoiesis, the patient will develop iron overload. The complications of iron overload will affect all organs of the body, including the heart causes heart failure, and the liver causes cirrhosis, and thyroid hypothyroidism, and pancreas diabetes, also delayed growth and sexual maturity due to deposition of iron in the gonads, unless chelation therapy is given. Secondary to splenectomy, these patients are liable to infection as well as blood transfusion transmitted viruses. Due to extramedullary hemopoiesis, we have a progressive enlargement of liver and spleen. So when the spleen becomes very enlarged, it will cause a trapping of a blood element with the destruction of RBC and other elements. This is what we call it hypersplenism. It increases requirement for a transfusion in this patient. And so we have to do splenectomy whenever the patient develops hypersplenism. This is a picture for a child with beta thalassemia major. You see upward slanted eyes, depressed nasal bridge with the prominence of facial bone. This is a skull X-ray film showing hair on end appearance. The lab diagnosis and complete blood picture hemoglobin level ranges from 2 to 8 grams per DL. There is microcytic hypochromic anemia. The blood film shows nucleated RBC due to active bone marrow, target cells, polychromasia, anisopoikilocytosis, and basophilic stippling. The MCV and MCH are significantly low. This is a peripheral blood smear showing anisopoikilocytosis, change in size and shape of RBC, basophilic stippling, fine blue dots in the RBC, teardrop cells, and target cells. All these findings can be seen in a blood smear of patient with beta thalassemia major. The other laboratory diagnosis to confirm beta thalassemia major is by doing hemoglobin electrophoresis, which shows elevated hemoglobin F to more than 50% with variable amount of hemoglobin A2. As a result of hemolysis, there will be unconjugated hyperbilirubinemia. The iron studies show high serum iron and ferritin levels. DNA analysis will detect deletions and mutation in beta globin producing genes. Usually, both parents have beta thalassemia trait. In this picture, you see the electrophoretic mobility of different types of hemoglobin in hemoglobin electrophoresis machine. In normal hemoglobin, normally there is a prominent hemoglobin A with a small amount of hemoglobin A2 and F. In beta thalassemia trait, there is decrease in hemoglobin A with increase in hemoglobin A2 to more than 4%, as we mentioned in the previous lecture. While in beta thalassemia major, the hemoglobin mainly hemoglobin F with almost absent hemoglobin A and increased hemoglobin A2. In sickle cell trait, there is increase in hemoglobin S and decrease in hemoglobin A. While in sickle cell anemia, the hemoglobin A is absent, there is mainly hemoglobin S with increased hemoglobin F. The management of beta thalassemia major is by repeated blood transfusion every 4 to 6 weeks with a fresh, filtered, washed, packed RBC to maintain hemoglobin to more than a gram per DL to prevent extramedullary hemopoiesis and deformity of the bone. Iron chelation usually starts after 10 to 15 units of the blood by using dysferrioxamine by subcutaneous infusion using special infusion pumps over 8 to 12 hours, 5 to 7 days per week. Another oral chelator is difirazirox or Xged. It has a few side effects and can be given as a single dose early morning, but it is an expensive drugs. As we mentioned, as a result of hypersplenism, splenectomy should be done. The only curative treatment is by doing stem cell transplantation from histocompatible sibling. The probability of survival exceeds 90% in well-selected cases. Gene therapy for stimulation of fetal hemoglobin production and somatic gene therapy. The last disorder is sickle cell disease. Here it is characterized by presence of hemoglobin S, in which glutamic acid has been replaced by valine at 6 amino acid of beta globin chain. This will give rise to different hemoglobin called hemoglobin S. It is characterized by the fact that in the oxygenated state, the red blood cell will lose their normal deformability and becomes sickle-shaped. These RBC are too fragile. They cannot withstand the mechanical trauma of circulation, so they will cause occlusion in microvascular circulation because they are distorted and inflexible RBC and easily adhering to vascular endothelia. Most of the patient will have asymptomatic periods alternate with a recurrent symptomatic episode. The most common clinical presentation is vaso-occlusive episode, which present with pain and they are recurrent in nature, causing irreversible organ damage. It can affect nearly all the organs in the body. It may occur early in first year of life as dactylitis due to infarction of microvessels in the small bones of hands and feet. That's why we call it hand-foot syndrome, but more commonly it presents later. The most common sites involved in vaso-occlusive crisis are bones, lungs, spleen, liver, penis, and the brain. The precipitating event for these attacks are infection, stress, dehydration, changes in temperature, hypoxia, or high altitude. The second clinical presentation is a transient red cell aplastic episode due to acute infection with parvovirus B19. This will lead to red cell aplasia with fever and pain. Usually, the parvovirus B19 affects the rapidly proliferating RBC, so it is common in patients with hemolytic anemia. The third presentation is acute sequestration episode. This episode usually occur in younger children when the spleen is still present, causing acute trapping of blood in the spleen and less frequently in the liver due to impaired egress of blood out of this organ and clogging by sickle cell. This will lead to enlargement of this organ and cardiovascular collapse. You know, in patients with sickle cell disease, the spleen usually disappears after the age of 5 years because of autosplenectomy secondary to repeated infarction of it. That's why this episode only present in younger children with palpable liver and spleen. Other clinical presentation is liability to repeated infection due to functional acyclemia. As we mentioned, the patient is liable to have autosplenectomy secondary to repeated infarction. However, also these patients, they have functional acyclemia, which can appear as early as 6 months of age until the age of 5 years in most children, because they found these children, they have their susceptibility to infection is similar to normal children after 5 years of age. The risk of infection is highest with encapsulated organisms like pneumococcus, Haemophilus influenzae, meningococci, and Salmonella species. These organisms need spleen for their destruction. Other clinical presentations are gallstones, chronic osteomyelitis due to recurrent attacks of infarction in the bones, chronic leg ulcers, lung disease, acute chest syndrome secondary to pulmonary infarction, renal disease, recurrent priapism due to blockage of the venous plexus in the penis, leading to continuous painful erection, which is an emergency situation in a child with sickle cell disease. Diagnosis of sickle cell anemia. In the blood film, we will see sickle cells with marked poikilocytosis and target cell. Screening test can be done for sickling by putting a drop of blood on the slide and covered by a cover slip. This will lead to a deoxygenation of the RBC and induce sickling. The definitive diagnosis by hemoglobin electrophoresis, which shows hemoglobin SS, as we mentioned. This is a blood film showing sickle cell RBC. This is a picture for long-term result of dactylitis and sickle cell anemia. A 18-year-old boy has shortening of the finger with his X-ray due to recurrent infarction of the microvessels of the hands. Treatment of vaso-occlusive crisis include a good amount of fluid by hydration, control the pain, giving the patient analgesic, and if it is severe enough, even narcotics can be given. Empirical antibiotics, because these patients are liable for infection with the previously mentioned encapsulated organism and sepsis. So when he develops fever, we should give him empirical intravenous antibiotic. Also, blood transfusion is indicated as a simple or exchange transfusion. In some cases, liable to have stroke in the vital organs like lung and brain. So in this patient, we give them blood transfusion to decrease the level of hemoglobin S to less than 30%. This is what we call it a chronic transfusion therapy in those patients. Prophylactic oral penicillin should be given at least until 5 years of age, as mentioned. Routine childhood immunization and annual administration of influenza vaccine are highly recommended. Medical intervention by stimulation of increased hemoglobin F production by giving the patient hydroxyurea, which is a cytotoxic drug used in some blood malignancies. On cellular and genetic level, it includes stem cell transplant in moderately severe cases, as well as gene therapy. Thanks so much.